بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسول الله الكريم. برحب بحضراتكم في المراجعة بتاعة الموديول الأولاني من الدبلومة، وهو على الشيست. في المراجعة بنعرض شوية حالات، وبعدين بنستنى الإجابة بتاعت حضراتكم على الشات، وبعدين أنا بكومنت على الإجابة، وأي حد بيكون عنده أي استفسار بيبعته برضو على الشات، وأنا بجاوب عليه أثناء المحاضرة أو بعد ما تنتهي كيفما يتيسر. معظم الكلام في الغالب بيكون بالإنجليزي، علشان زمايلنا اللي هم موجودين في الدول اللي ما بتتكلمش بالعربي ممكن يعرفوا يستفيدوا من المراجعة ديت إن شاء الله. هنبتدي بإذن الله. And this is the first case. A female patient, 28 years old, presenting by chest pain and productive cough. And this is her CT scan. Yes, and this is a good answer. The answer is right. This is a case of lymphangitis carcinomatosa. And you see the mass in the breast, which is the primary malignancy. And you see some lymph nodes in the axilla, as well as thickening of the skin of the breast, diagnostic of breast cancer. And whenever you see interstitial opacities in the lung, especially in the pre-lymphatic distribution, meaning that you can see some nodules arranged along the interstitial spaces, then you think of interstitial lung disease. And the most two common lesions that they cause lymphangitic spread are the sarcoid and the lymphangitis carcinomatosa. And the difference, of course, is well known to all of you. Whenever you see or you know that the patient had a primary malignancy, then the diagnosis of lymphangitis is selected. Female patient, 40 years old. She presented by severe dyspnea, and she has a long history of intravenous heroin and cocaine intake. Yes, tension pneumothorax. What about the right lung? Yes, and this is right, septic emboli. And you can see, and of course, you see a pneumothorax on the left side. And this is not just a pneumothorax, there is some fluid level, and it is a hydropneumothorax, I mean. And if you look to the opposite lung, and you can see multiple cavitating pulmonary nodules. And these cavitating pulmonary nodules, in view of drug abuser, then you should suspect confidently that you are dealing with a case of septic pulmonary emboli. And one of the known complications of septic pulmonary emboli is one of these cavitary lesion ruptures into the pleural cavity, resulting in this pneumothorax. This is not tension because the heart is almost at its side, and the diaphragm is not the breast, but there is fluid, and you should notice this, and this is hydropneumothorax. Next case is a chest X-ray, and you may easily appreciate the opacity present in this X-ray. No, this is not actually a Bankus tumor. This is a lesion which is located adjacent to the aortic arch. and it is in the range of a pulmonary mass and should consider any pulmonary mass in an adult representing a bronchogenic carcinoma until proved otherwise. And a mass like this is considered from the plain film to represent bronchogenic carcinoma. And you may say Bankus tumor, whenever you see the mass, is affecting one of the adjacent ribs at the apex of the lung. Next case. This patient is clinically suspected to have pulmonary embolism, and they had this CT scan. Yes, and this is one of the names of this lesion, hairy atelectasis or round atelectasis. And this round atelectasis has a very characteristic appearance on the CT scan. You got a pleural-based opacity, and the inner margin of the opacity is serrated, or let us say, it's exactly similar to this appearance. And it is known as a parachute sign or comet tail sign, but this lesion may be mistaken for bronchogenic carcinoma because of the speculated inner margin. And you should know that these lesions on PET scan will show metabolic activity. And that's why I receive many cases to have a biopsy from this lesion on the assumption that this is a bronchogenic carcinoma. And I say this is round atelectasis because of the very characteristic appearance, but some of the physicians insist on taking a biopsy, and the biopsy results will be an atelectatic lesion. Next case is a male 72 years old, and these some selected images from his CT scan. Yes, and this is pulmonary embolism, bilateral pulmonary embolism. You see the filling defects in the, let us say, the second or the third order branch. And on the left side, and you can see some similar lesions, but on the right side, they are clear enough. And you should be careful about this because many of the pulmonary emboli, especially the more peripheral ones, may be missed during the study. Next case is a lesion, and this is the progression of the lesion in the right upper lobe. Yes, this is right. This is bronchogenic carcinoma and is cavitating bronchogenic carcinoma. The main differentiating point here is the lung abscess, and lung abscess should have a smooth inner margin, but an uniform wall thickness, but this is an extremely irregular wall thickness and extremely irregular inner margin, diagnostic of cavitating bronchogenic carcinoma. This male patient, 69 years old, is retired coal miner, complaining of shortness of breath for several months. Yes, right. And this is a good answer. This is pleural plaques. You should, as I have mentioned before, you should look to the diaphragm. And if you see some calcified plaques on the diaphragmatic copula, and you consider all these opacities belong to the pleura, and this was right in the CT scan, and you can see multiple calcified diaphragmatic pleura and the costal pleura as well, diagnostic of calcified pleural plaques. Next case is a male child, 1 year old, and this is the initial scan, and this is the follow-up after 1 year. Mm, No, this is not cystic fibrosis. Actually, cystic fibrosis does not start like this, and this is also not a cryptogenic, no. Hydatid cysts, no. Wegener, no. CCAM or CBAM, no. Yes, this is the right answer. Langerhans cell histiocytosis. And you know that Langerhans cell histiocytosis results from infiltration of the pulmonary parenchyma by histiocytes, and this will result in the formation of pulmonary nodules. And these nodules will later on cavitate and form multiple cavities. And these cavities are not of uniform size. They have appreciable wall thickness. They are distributed throughout the lung, and they may spare the lung bases. They are commonly seen in the upper lobes and middle lobes. And this is a case of Langerhans cell histiocytosis. Next case, and you see this patient had a previous thoracotomy, and there is a big mass, let us say, big mass here, and the lateral chest X-ray, the mass is projected anteriorly. Then what do you think? Aortic aneurysm, mediastinal mass, thymoma. Okay, let us see the CT scan of the same case, and this is the CT scan. You see two big masses on either side of the mediastinum, and also you should notice that one of these masses has invaded the superior vena cava. Then in such a condition, what do you think? Yes, thymoma is most likely. Yes, this is right, because thymoma has tendency to invade the superior vena cava, and at that time it is known as invasive thymoma. The second, or let us say the first most common mass that will invade the superior vena cava is the bronchogenic carcinoma. But if you say that this is a bronchogenic carcinoma, what about this? And you should consider these two masses as a single lesion. If you consider this, and then you say the most likely answer will be invasive thymoma. Next case is a male patient, 55 years old, presented by progressive shortness of breath. Yes, and this is usual interstitial pneumonia, typical appearance of usual interstitial pneumonia. And you should have three main findings to diagnose usual interstitial pneumonia. Number one, interstitial opacities. Number two, traction bronchiectasis. Number three, honeycombing. And this honeycombing is the most important finding to diagnose this possibility. And you should not diagnose usual interstitial pneumonia or idiopathic pulmonary fibrosis unless you see this pattern, which is the honeycombing. Then when is according to the recent classification of usual interstitial pneumonia, and you got definite diagnosis and possible diagnosis. And a definite diagnosis is established whenever you see honeycombing, traction bronchiectasis, and interstitial opacities, as well as ground glass lesions. If you do not see honeycombing and you see the rest of the finding, traction bronchiectasis, interstitial opacities, and the ground glass, this will be non-specific interstitial pneumonia. If you do not see traction bronchiectasis nor honeycombing, and you see only ground glass opacities and interstitial reticulations, this will be hypersensitivity pneumonitis. Next case is a female child with known systemic lupus, and you got this lesion in her right lung. Pneumonia. Other possibilities? Bronchogenic lymphoma. Yes, okay, very good. If you see a lesion with internal air bronchograminy, you have three possibilities. And these three possibilities are round pneumonia, lymphoma, and alveolar cell carcinoma. We do not usually diagnose round pneumonia unless you got a positive history of pneumonia, meaning that the patient had cough, fever, and expectoration. Then if you do not have positive data to diagnose pneumonia, then you go to the other two possibilities, either lymphoma or alveolar cell carcinoma. And many times we can resort to the biopsy to reach the diagnosis. But I will, and of course, you know, many of the supportive finding to assess the possibility of alveolar cell carcinoma, especially whenever you see an obesity with adjacent pulmonary nodules. Next case is a chest X-ray showing this opacity. Yes, ممتاز. Very good. This is the S sign of Golden, which means that you are dealing with a bronchogenic carcinoma. The S sign of Golden means that there is a central bronchogenic carcinoma on the right side that has obstructed the upper lobe and resulted in upper lobe collapse. And this will result in this configuration, which may simulate the letter of S. Next case is a male patient with 60 years old with history of increasing shortness of breath and heavy metal exposure. He is a non-smoker. Yes, the answer is right, and this is progressive massive fibrosis, two big masses on either side of the mediastinum, and the masses may contain calcium. Adjacent to the masses, there are many nodules, which represent the nodules of pneumoconiosis that will coalesce together to form these two big masses. I thought at the time that this is a rare condition to be seen in the clinical practice, but surprising enough, I see just a few days ago a case, and the possibility of progressive massive fibrosis was not considered by the junior staff because they usually think that this is a rare condition not seen in the clinical practice. Next case is a chest X-ray of a female 50 years old with dry cough, dyspnea on exertion, and some inflammatory changes with mild fever. And I provide some of the differential diagnosis: TB, alveolar sarcoid, lymphoma, and alveolar cell carcinoma. TB, yes. Okay, actually, TB is one of the good possibilities, especially for the area where we are living. And you got patchy opacities, nodular lesions, and most of the lesions are located in the upper lobes. You may think of this, but alveolar sarcoid can provide this appearance also. Lymphoma can show this appearance, and alveolar cell carcinoma can also appear like this. What is the report that you should give it to the patient? You say that I am dealing with bilateral non-symmetrical opacities in both lung fields, together with the numerous scattered pulmonary nodules. And I do not see evidence of enlarged lymph nodes, and the schizophrenic angles are clear. This mixed appearance is for the differential diagnosis, and the diagnostic possibilities include so and so and so. And I am not one of who like the recommendations in the report. And do not say recommended for CT or MRI or guided biopsy. Let the physician behave according to his He's collected data about the patient, the clinical data, the lab data, and the radiological data as well. Next case is a male patient, 72 years old, presented by dyspnea and chest pain. And I provide these possibilities. Yes, and this is a typical appearance of a Bankus tumor. If you look carefully here and you see a big mass in the apex of the lung, and you see destruction of at least one of the ribs. The first and the second ribs are destroyed. This is diagnostic of Bankus tumor or the superior sulcus tumor. Next case is a chest X-ray, and they got opacity on the left side. Tension pneumothorax, no. There is no pneumothorax actually. The hernia, right upper lobe collapse, left mastectomy here. Okay. Then if you look here and you see that the diaphragm is elevated and the left hemithorax is somewhat opaque. If you look to the lateral view and you see that the opacity is projected anteriorly, and you can know that the opacity is anterior from the silhouette sign with the cardiac shadow. And this is left upper lobe. And left upper lobe loss of volume and opacity means consolidation and collapse. And this is left upper lobe consolidation and collapse. Actually, many or sometimes this collapse will result from a neoplasm that has obstructed the bronchus. But if you look to the region of the hilar shadows clear of any opacity to suspect this, this is simple left upper lobe consolidation collapse. Next case is a chest X-ray with this opacity. Yes, someone said that the foreign body may give such an appearance sometimes, but in this age, and the adult age, the foreign bodies are not that common compared to the pediatric age group, and some of the foreign bodies may be radiopaque and you see them. But actually, you do not interpret any radiological procedure without the clinical data in order to reach the correct diagnosis. But I'm trying to give you some of the clinical data whenever they are necessary, and I test your thinking in cases of simple lesions as they do in the exams, but I do not like to present cases without history, but this is usually seen in the clinical exams. And this is the next case. What do you think? Yes, this is a question says why the cardiac shadow is not seen in the presence of an opacity in the lung. If the opacity in the lung is anterior and the heart is anterior, then the opacity will cover the heart, and this is known as positive silhouette sign. But if the opacity is posterior and the heart is anterior, the opacity will not cover the heart, and I will show you a case like this. The answer for this is right lower lobe consolidation, and this is the right answer. You got an Apache opacity with internal air bronchogram, meaning that is consolidation. Then if you look in the lateral view, you see the opacity is posterior, And I said that the only posterior lobe on both lungs is the lower lobe. The lower lobe on the left and the lower lobe on the right lie on the spine. Next case, there is a lesion in the CT scan, and these are the possibilities: tuberculoma, bronchogenic hamartoma, aneurysma, hydatid cyst. Yes, the answer is hamartoma, and hamartoma is right because there is a smooth margin in spite of absence of calcium, and you got internal hypodensities representing fat. And fat is one of the classic criteria of hamartoma. Of course, if you see popcorn calcification, it will facilitate reaching the diagnosis. Next case is a 33 years old male with dyspnea. And in the previous case, there is no calcium in the lesion, but there is fat. Mass in the lingula and bronchogenic or pericardial effusion. Okay. If you look for this lesion and you see, and there is a big mass on the left side, if you look to the cardiac border, you cannot see the cardiac border, meaning that this mass is anteriorly located. Then, as you know, if you are dealing with a mass in the lung of an adult, you think of a bronchogenic carcinoma until proved otherwise by having another imaging modality like this, for example. And this is the CT scan of the same case. Then what do you think? Fungus teratoma. Teratoma is the right answer because of the presence of fat. This is an anteriorly located mass, as I said, and you got fat fluid level. This is a mass of soft tissue mixed by fat, and this is fluid, and this is fat, and all these components, especially if calcium is present, are diagnostic of mature teratoma or teratodermoid cyst. Next case is a patient with a motor vehicle accident and multiple fractures and the chest X-ray, and this is the follow-up 2 days later. Yes, contusion, right. If you got an opacity in the chest after trauma, there are 3 possibilities. Number 1, pulmonary contusion, the first of all. Number 2, fatty embolism. Number 3, aspiration pneumonia. The pulmonary contusions clears very fast compared to other lesions. Then in a day or two, there is clearance of the lung, meaning that this is pulmonary contusion. Next case is a chest X-ray, frontal view and lateral view. These are the possibilities: normal chest X-ray, hilar lymphadenopathy, central bronchogenic carcinoma, emphysematous chest, bronchogenic hilar lymphadenopathy. Okay, then you see a big mass here, and this mass is projected here. Then this may represent a lymph node or may represent a mass in the central part. Then if you look to the CT scan and you see that there is actually a mass, and this mass is immediately posterior to the hilum, and it shows the classic appearance of a speculated margin, diagnostic of bronchogenic carcinoma. And the speculation is sometimes referred to as explosion. Explosion, like the bomb explosion, and you got too many opacities around the lesion, and this is diagnostic of malignancy. Next case is a female patient, 50 years old, with this chest X-ray. Pneumonia or mass, left lower lobe mass, yes. And this, you see an opacity superimposed on the apex of the heart. This is the lateral view. And the lateral view showed actually there is a mass in the left lower lobe. Then these are the diagnostic possibilities: bronchogenic carcinoma, hydatid cyst, or metastatic deposit, as you know from the lectures. What do you think? Yes, right. You should diagnose this as bronchogenic carcinoma, but if you know that the patient had leiomyosarcoma of the uterus, then you know that this is a metastatic deposit. And if you see a mass in the chest and you do not know anything about the patient clinical data, or you do not see something that can point to a primary malignancy like mastectomy, for example, or something like this, then you diagnose this as bronchogenic carcinoma until proved otherwise. Then this is a chest X-ray, and these are the possibilities: bronchogenic carcinoma, left upper lobe collapse, left lower lobe collapse, posterior mediastinal mass. Yes, very good. Actually, in the most of you answered the right answer, which is the left lower lobe collapse. And you know that the left lower lobe, when it collapses, it go posterior to the heart because the lower lobe is posterior, and it will form a triangular-like opacity posterior to the cardiac shadow. This will result in volume loss and tracheal shift, and also sometimes mediastinal shift to the same side. This is left lower lobe consolidation collapse. Next is a chest X-ray showing a lesion on the left side. Yes, massive effusion. Yes, massive effusion is the right answer. But I have said that whenever the pleural effusion is massive, you should consider an underlying malignancy. And this malignancy may be in the lung, may be in the pleura, or maybe in the mediastinum. But these patients should go for a CT scan to assess the possibility or to see the malignancy underneath, if it is in the pleura, like mesothelioma or metastasis, in the lung, like bronchogenic carcinoma, as proved in this case. Next case is a chest X-ray, and these are the possibilities: normal, emphysema, emphysematous bulla, encysted pneumothorax. Yes, emphysematous bulla is the right answer. Actually, in the case of massive effusion, evaluation by ultrasound is possible. And this is a very good idea to save the radiation for the CT scan. And I think whenever you diagnose the underlying malignancy, you will need the help of CT for staging. This case is emphysematous bulla, as you can see. The chest is emphysematous, and there is a big bulla with characteristic appearance, very thin margin, and radiolucency with no internal air fluid level. Two lesions in the lung, and these are the possibilities: lung metastasis, abscess and bronchogenic, hydatid cysts. Yes, hydatid cysts. Right, and actually, if you see a lesion like this and another lesion like this, sometimes you got multiple lesions, one of them containing air fluid level, then you should suspect that these lesions will represent hydatid cysts, and one of them is intact or one of them ruptured, and the rest of the hydatid cysts are intact. Then this is a child with this lesion in the left upper lobe, lung metastasis, neuroblastoma, hydatid cyst, round pneumonia. Yeah, okay. I said you should not diagnose round pneumonia unless you have positive history of pneumonic symptoms like fever, cough, and expectoration. Also, you should not diagnose metastatic doses unless you have positive data of the presence of primary malignancy, especially if the lesion is solitary. Then these lesions should be looked for, especially from the clinical data. Whenever I did not provide you by the clinical data that direct you to the diagnosis of round pneumonia, then you know that this is not round pneumonia. But what happens if you are in the exam and you say the possibilities, all of the possibilities, then you explain your point of view. If the patient had pneumonic symptoms, this should be the round pneumonia. If the patient is totally asymptomatic, then you may think of the hydatid cyst. If the patient had a primary malignancy, then this may represent metastatic deposit. Then this is a chest X-ray also, and the possibilities TB, upper lobe pneumonia, lung metastasis, left upper lobe collapse. Yes, TB. Yes, metastasis will be multiple well-defined lesions, but this is the fluffy opacity. Or I mean that they are extremely ill-defined, patchy and nodular and strandy. All of these are classic criteria for TB. Next, this is a polytrauma patient received large amount of intravenous fluid in a short time to treat the severe blood loss. This is the initial chest X-ray, and this is the follow-up chest X-ray. Yes, pulmonary edema, yes, you are right. And this is pulmonary edema because of the fluid overload. And you got fluid overload, then you got pulmonary edema. And on the follow-up after some care, you got resolution of the edema. Next case is a patient with 2-day history of cough and shortness of breath. The body temperature is about 38. Then pneumonia, edema, hemorrhage, progressive massive fibrosis. Yes, and I give you the clue for the diagnosis. If the patient had fever, then the cough, then you think of pneumonia. Why you go for hemorrhage, and you do not have a clinical support to diagnose hemorrhage. And this is patchy opacities with air bronchogram, then you think of pneumonia. Especially the clinical data supports the diagnosis of pneumonia. In the exam, please don't go for odd diagnoses, considering that you are in the exam. But you should diagnose the straightforward condition first. If you feel that this is not the right answer, but if you go common by common, you will reach the diagnosis. And next case is this lesion and left upper lobe collapse, bronchogenic carcinoma, thymic tumor, neurogenic tumor. Carcinoma, left upper lobe, thymic tumor, left upper lobe collapse, left upper lobe collapse, bronchogenic carcinoma. Okay, then you look for this diagram, then you see that there is a mass here, and this mass has compressed a little bit the trachea, and there is considerable elevation of the diaphragm. Then if you consider this as a bronchogenic carcinoma, it will affect the phrenic nerve and cause phrenic nerve paralysis with consequent elevation of the diaphragm. But if this is the left upper lobe, the left upper lobe is anteriorly located. It will cover the heart. It will cover the heart and the aortic arch. This is not a, a lower lobe, an upper lobe collapse. This is a mass with phrenic nerve paralysis. Then in this case, you can see a very characteristic sign which can help you later on. This sign is known as Loof-Sichel sign. Loof-Sichel sign. In cases of bronchogenic carcinoma obstructing the upper lobe bronchus, the upper lobe will collapse. Then the right upper lobe will hyperexpand, and this hyperexpansion will cross the mediastinal border and form an air crescent along the arch of the aorta. This is what we call Loof-Sichel sign. If you see this Loof-Sichel sign, you know that you are dealing with a bronchogenic carcinoma that has resulted in upper lobe collapse and a herniation of the hyperinflated right upper lobe to the left side. And this is another example. You see an extra density here, which represents the mass that has resulted in upper lobe collapse, and you can see the Loof-Sichel sign. On the CT scan, you see the mass, and you see the herniation of the upper lobe, and you see the Loof-Sichel sign, and here is the collapse, loss of volume, and herniation of the upper lobe to the opposite side. And this patient is known to have cancer bladder. Then what is the diagnosis? And the mass does not cause silhouette because of the herniation of the right upper lobe to the opposite side. And this will result in the air, which prevent the silhouette sign. And here is metastasis, of course, but you should mention also the remaining findings. And you got metastasis, of course. Then what about this? There is air in the pleural space. And what about this? There is fluid level in the pleural space. Then you got metastasis and hydropneumothorax. And this is an important part of the exam that you will undergo in few days. Will be some questions like this. And I put the case, and I say, please identify 2 findings or 3 findings or 4 findings. Then you have to look where are these 4 findings in the images provided. Next case is a female patient, 76 years old, and you got this mass around the descending aorta. If you want some of the differential diagnosis, I provide aortic aneurysm, bronchogenic carcinoma, pulmonary lymphoma, and a neurogenic tumor. Lymphoma. Yes, this is right. This is pulmonary lymphoma. And it is not an aortic aneurysm, of course. It is not a neurogenic tumor. And the 2 most likely possibilities are the bronchogenic carcinoma and lymphoma. Bronchogenic carcinoma invade the mediastinum, but lymphoma encase the vessels, and you can see some very smooth encasement of the descending aorta. Next case is the male patient, 43 years old, with cough and fever. Yes, pneumonia. Of course, but is there any other finding in the film apart from pneumonia? Pneumonia, collapse, pneumonia. Hilar mass, very good. Yes, very good. And the possibility of a lesion here is suspected, only suspected. I'm not sure about this, but if you see the CT scan of the same patient and you got a lesion which corresponds to this area, and this lesion is cystic and is located in a very characteristic location, diagnostic of bronchogenic cyst, yes. And this is bronchogenic cyst and pneumonia. Then this image, when I provide in the exam, I said there are two findings. Then you say there is pneumonia. Then you say also, I suspect, and I'm not sure about the presence of a mass in the mediastinum. Then next case is a patient with renal cell carcinoma. Actually, the previous case is I said in the literature, in the lectures, that bronchogenic carcinoma and esophageal duplication cyst, both lesions can exist each at the location of the other lesion, meaning that an esophageal duplication cyst is located at the carina, yes. A bronchogenic cyst is located near the diaphragm, yes. But whenever the cyst is located in a typical location like this, exactly in the carina, you should say first that this is a bronchogenic cyst. Whenever you are asked about the differential diagnosis, you say this may represent an esophageal duplication cyst. Then what do you think about this? Some said that this is pericardial cyst or pleuropericardial cyst. Okay, what about for the renal cell carcinoma? Do you feel that this lesion may represent metastatic deposit? Maybe, why not? And you have a positive history of malignancy. Then you should verify this possibility by CT, and this is CT. And you got a lesion, and this lesion is cystic with marginal calcification. Then you say, can this lesion be a metastatic deposit? What do you say? No. No, this lesion cannot represent a metastatic deposit. It's a benign lesion because of many criteria: clear fluid, regular wall thickness, calcification in the wall, absence of internal septations, absence of solid mural nodules. Then you think of a benign lesion in spite of, that the patient had a primary malignancy. Then starting to analyze the benign lesion, which can give this appearance. Then you think of hydatid cyst, and I say hydatid cyst almost never calcify in the lung. Then you think of a mediastinal cyst, and this is true because mediastinal cysts can show internal calcification and can also show internal septations and mural calcification. Then this is a mediastinal cyst. And according to the location, it it looks like a pleuropericardial cyst. But whenever this cyst was aspirated, it was proved to be of thymic origin. And this is not your business, as they said. You say this is a benign lesion at the mediastinal in location, and the diagnostic possibilities include pleuropericardial and bronchogenic cyst. Next case is chest X-ray. No, this is not an aneurysm of any normal chest X-ray. Normal chest X-ray, and this is one of the common mistakes seen in the clinical practice. Whenever you look in a hurry for the chest, then you forget to look for the cardiac borders. You see, the left cardiac border is well defined, the right cardiac border is masked by this opacity. Then the opacity is anterior, and this is the site of the middle lobe, and the diagnosis is middle lobe pneumonia. Okay, next case is a chest X-ray, and you see these changes on the right side, and these are the possibilities: TB, lung collapse due to malignancy, infected bronchiectasis, cystic lung disease. TB, very good. Yes, and this is TB. And TB can cause collapse. TB can cause bronchiectasis, of course, due to chronic inflammation and traction on the bronchi. TB can cause pneumonia. TB can cause pleural effusion. All the manifestations can be explained on the basis of TB. Next case is a chest X-ray, and these are the possibilities: mild pleural effusion, mesothelioma, emphysema, pneumonia, and effusion. The diagnosis of pneumonia and effusion, yes, this is right. Pneumonia and effusion. And you see that there is opacity representing pneumonic consolidation and pleural effusion. When to diagnose emphysema, if you see the effusion is encysted, and you got the possibility, you say this is encysted pleural effusion, which may be secondary infected, but this effusion is not encysted. It has the meniscus upper border. Then this is not an emphysema, and of course is not a mesothelioma. There is no pleural thickening, and this is not just a pleural effusion because there is opacity of the underlying lung, and this is pneumonia and diffusion. Next case, the CT scan post contrast, and these are the possibilities: encysted diffusion, mesothelioma, multilocular emphysema, lung abscess. Emphysema. Okay, multilocular emphysema, very good. This is emphysema because the lesions are located in the pleural cavity. They are encysted, they have thick enhancing margin, and the underlying lung is collapsed. Then this is diagnostic of pleural infected collections, which means that you are dealing with multilocular emphysema. CT and MRI of a mass here, and these are the possibilities: thymus, normal thymus, thymic lymphoma, thymoma, retrosternal thyroid. Thymoma, yes, their answer is right, and this is thymoma. The most common solid anterior mediastinal mass, which does not contain fat, is the thymic tumors. And these thymic tumors may be due to thymoma or thymic lymphoma, the same. But in order to diagnose retrosternal thyroid, you should see the continuation of the lesion into the root of the neck. And to diagnose other anterior mediastinal masses, you should find fat to diagnose teratodermite. Next case. And this is a male patient, 65 years old, with chest pain. Yes, normal thymus in children, but persistence of the thymus in the adult age can be also seen. And sometimes the thymus will be hyperplastic in response to stress conditions like surgery and others. Then this chest X-ray, how we differentiate from thymoma. We differentiate the normal thymus from thymoma by the configuration. The thymus is like in the sale sign or the figure of 8 in Arabic, and the thymic mass does not look like the normal thymus. There are many possibilities for this chest X-ray, and do not diagnose pneumodiastynum unless you see air in the neck. I said that very clearly. And all what you can see here is that the aorta is dilated and unfolded, the lungs are clear, and nothing else. But if you look to the CT scan of the patient and you see a big lesion in the pulmonary trunk, then what do you think? Yes, pulmonary embolism. Okay. And I said this is not pulmonary embolism because of these two possibilities. Number one, affection of the pulmonary trunk. The affection of the pulmonary trunk is not seen in pulmonary embolism. This affection will result in sudden death, and the patient is not alive to do a CT scan and to be injected with contrast. Pulmonary embolism is in the main arteries, not in the pulmonary trunk. Number two, the lesion is enhancing, and the embolus does not enhance. This means that this is a tumor, and the tumor arising from the pulmonary artery is the leiomyosarcoma, not an angiosarcoma, the leiomyosarcoma of the pulmonary artery. هذا وبالله التوفيق. أنا شايف إن أنتوا ما شاء الله يعني مذاكرين كويس وبتجاوبوا بطريقة مرضية جدا، ونتمنى إن العزيمة ديت تفضل معاكم على طول لحد لما نخلص المهمة اللي احنا اطلعنا بيها أنا وإنتم، علشان إن شاء الله في نهاية السنة يكون كل واحد منكم واقف على رجليه وقفة جامدة جدا، ويكون حصل قدر كبير جدا من المعلومات اللي بتساعده في إن هو يجتاز أي امتحان يتعرض له، أو يعني يبلي بلاء حسنا في الشغل اللي هو منوط بيه. وإحنا هدفنا زي ما قلت وبقول إن إحنا عاوزين نوصل إلى إن الإنسان يكون competent، علشان نمرة واحد يرضي ربنا، نمرة اتنين يبقى محترم قصاد نفسه، نمرة تلاتة يبقى محترم قصاد المريض. وخلي دايما الثلاث أهداف دولت في ذهنك، وعاوزك تبذل أقصى ما في وسعك معايا في السنة ديت علشان نوصل بيها للتارجت اللي احنا عاوزينه. وما تاخدش الموضوع يعني بالراحة، لا، انت اعتبر نفسك في هذه السنة يعني مسألة حياة أو موت زي ما بيقول. أنا عاوز أبقى إنسان كويس محترم ومصر على هذا، وهبذل قصارى جهدي، وكل الناس اللي معايا اللي بيتابعوكم وكده ما بيتأخروش عنكم في أي حاجة. وأنا برضو نفس الحكاية، برد على جميع الأسئلة اللي بتجيلي على التليفون بتاعي أو اللي بتتبعت لعبد الله وشديد وكده، وهم بيبعتوها لي. احنا كلنا آه، هدفنا ان احنا ان شاء الله نكون حاجة كويسة جدا جدا، ننفع نفسنا وننفع بلدنا وننفع الناس كلهم يعني بإذن الله تعالى. آه، احنا طبعا آه، يعني الدبلومة بتحاول بقدر الإمكان إنها تبتدي من البيزك على قد ما نقدر. ولكن زي ما حضراتكم عارفين ان في اي كورس طويل لازم يكون فيه بري ريكوزيتس، ولازم يكون فيه شوية يعني استعدادات نفسية وذهنية وعلمية للواحد عشان يعرف يمشي في الكورس. فاحنا كنا دايما بنقول للناس اللي هي عاوزة تدخل الدبلومة، لو انت ما عندكش فكرة خالص عن الأشعة هيبقى صعب، لان كان بيجي لنا ناس دكاتره امتياز وحاجات زي كده. فاحنا على الاقل بيزك ريكوايرمنت ان يكون واحد قضى في شغل الاشعه يعني على الاقل 6 شهور، يكون عرف شويه معلومات وحط رجله كده على الارض وكده. واحنا بعد كده بنبني المعلومات المهمه وكده. لكن مثلا ما عندناش محاضرات في البيور فيزيكس ولا مش يعني بعض الحاجات اللي هي كانت بتدرس في الفيرست بارت بتاع الماجستير. احنا بروفيشنال دبلومه وما احناش اكاديميك، احنا عاوزين نعلم، خلينا نسميها كلينيكال دبلومه. عاوزين نحط نفسك على طريق التشخيص الصح، طريق الامتحانات، بالرغم من كل تحفظاتنا على موضوع الامتحانات ده. لكن القضيه كلها احنا عاوزين نوصل بحضراتكم إلى سيف راديولوجيست، يعني راجل مالي هدومه، بيشخص كويس وبيتصرف كويس وعارف حدوده، إن هو لما يوصل إلى حاجة معينة لا يجتاز الحواجز ويقف في الحتة ديت لحد لما يراجع، يسأل حد كبير، يخش على النت، يعمل زي ما احنا كلنا بنعمل. يعني انا واحد من الناس ما اعرفش اشتغل الا وانا عندي انترنت كونكشن، لان في حالات بتجيلي انا ما اعرفش ايه دوت، فبدخل على النت وبدور واروح واجي وافرك واحرك والكلام ده كله علشان اعرف في الاخر خالص ايه هو التشخيص. كلنا بنعمل كده، وديت ما فيهاش اي حاجه خالص، كلنا بنتعلم لحد لما نموت. وبالتالي بنرجو ان حضراتكم تواصلوا معنا المسيره بنفس الطريقة بنفس العزم، علشان إن شاء الله نحقق التارجت بتاعكم بإذن الله، ونؤدي الأمانة اللي أنتم علقتوها في أعناقنا. ونتمنى لكم التوفيق دايما، والسلام عليكم ورحمة الله.